One chance to get it right. The aim of this presentation is to remind you of the priorities of care for the dying patient and to empower professionals in their care. It is important to reflect upon the sequence of events that have occurred in the last 2 years with respect to the care of the dying patient and those important to them. You will, I'm sure, already have given consideration to this important issue and what led to the publication in July 2014 of the One Chance to Get It Right. 51% of UK deaths occur in NHS hospitals. Dying patients, therefore, are an integral part of the population of general hospitals. Their death must not be considered a failure. The only failure is if a person's death is not as restful and dignified as possible. Studies would indicate that 40% of acute admissions to a hospital are for patients in the last year of life. Forecasts would predict that the mortality rate is set to rise over the next decade, resulting in a rise in the overall number of deaths and a possible increase in the percentage of deaths occurring in hospital. As a senior registrar in palliative medicine in the 90s in Liverpool, I was involved in the development of the Liverpool Care Pathway. Its aim was to transfer best practice for the care of the dying from the hospice to the hospital setting. It highlighted areas of importance, provided advice on approaches to delivery of care and the expected outcomes of care delivery. The Liverpool Care Pathway provided guidance on the assessment and care of the dying patient. It helped in the recognition of and the provision for common symptoms encountered in the dying patient. It provided guidance on comfort measures, the anticipatory prescribing of medicines, discontinuation of interventions no longer necessary, psychological and spiritual care, and care of the family before and after death. However, increasing media attention to the concerns of relatives led to the independent review of the Liverpool Care Pathway. The independent review was published in July 2013. It had been commissioned by the Minister for Care and Support in response to concerns expressed by families and criticisms levelled at the LCP in the media. It was chaired by Baroness Julia Neuberger, and it identified clear failings in some areas of care and recommended that the LCP be phased out. It recommended that the government set improved quality for the care of the dying as a priority. This article was written by Anthony Wrigley from the Centre for Professional Ethics in the School of Law at Keele University. Written and first submitted in the aftermath of the Neuberger report, it was reviewed and accepted for publication in the Journal of Medical Ethics early in 2014 and subsequently appeared in the May edition. It stated that while evidence gathered of poor incidences of practice by the review is of genuine concern for end-of-life care, the inferences drawn from this evidence are inconsistent with the cause for the concern. Seeking to end an approach that is widely seen as best practice and which genuinely delivers high-quality care because of negative impressions formed from failing to implement it properly is not a good basis for radically overhauling our approach to end-of-life care. However, Anthony Wrigley did agree that there were problems with decision-making and communication, concerns over hydration and nutrition, and concerns over the deliberate hastening of death. In response to the independent review, the government established the Leadership Alliance for the Care of Dying People. Comprised of 21 national organisations, they took collective action to secure improvements in the consistency of care given in the last days and hours of life in their families, and led to the development of the 5 priorities of care. The One Chance to Get It Right was published in July 2014. Within the document, One Chance to Get It Right, there are two main definitions of care. End-of-life care, for those approaching the end of their life in months and years, and the care of the dying, for those thought likely to be in the last hours or days of life. The 5 priorities of care were to recognise and communicate, involve, support, plan and do. The identified priorities for care of the dying person are as follows. Recognise. The possibility that a person may die within the next few days or hours is recognised and communicated clearly. Decisions made and actions taken in accordance with the person's needs and wishes, and that these are regularly reviewed and decisions revised accordingly. That we should always consider reversible causes such as infection, dehydration, hypercalcemia, etc. Communicate. That sensitive communication takes place between staff and the dying person and those identified as important to them. Involve. The dying person and those identified as important to them are involved in decisions about treatment and care to the extent that the dying person wants. Support. The needs of families and others identified as important to the dying person are actively explored, respected and met as far as possible. Plan and do. That an individual plan of care, which includes food and drink, symptom control and psychological, social and spiritual support, is agreed, coordinated and delivered with compassion. So this is what is expected of professionals. How do we communicate with families? How do we recognise in patients for whom the outcome is uncertain or that they may be sick enough to die? Often they may be patients admitted with acute deterioration superimposed on a progressive decline. They may have significant comorbidities. It's important that we determine patients' and families' expectations, preferences and wishes. We need to identify any potentially reversible conditions. We need to agree treatment decisions, which may be a trial of treatment, with the multi-professional team, with the patient and with the family. And that means all treatment interventions, whether that mean nephrostomy, antibiotics, cardiopulmonary resuscitation, hydration, nutrition. We need to ask ourselves if specialist palliative care support required. We need daily assessment of a patient's condition and treatment decisions and touch base with the family. We need to acknowledge with the patient and the family if there is no response to treatment. We need to continually review the plan of care, and we need to clearly document the discussions we have with patients and families. How do we recognise that somebody is sick enough to die? How do we communicate this possibility to the patient and the family? And how do we make decisions and act according to patients' wishes and preferences, review regularly and revise our decisions in the light of that regular review? How do you or your team recognise that someone may be sick enough to die? What we must do, however, is have competent senior medical assessment. We need to exclude reversible causes. We need to include the views of the wider multidisciplinary team. We need to identify clear goals of care and discuss through discussion with our patients. We need at least daily senior clinical review. We need a second opinion if doubt exists. And staff must seek out carers to communicate any change in condition or deterioration. Communication. Sensitive communication is required between the staff and the patient, and between the staff and those important to the patient. Following that communication, What are the important things that we need to document following any conversation about the possibility that a patient may be sick enough to die? Communicate. What we must do. We must talk with the patient and the family. We need to listen, respond sensitively to issues and concerns. We need to provide information, whatever's required. We need to check their understanding. Use simple, appropriate, straightforward language, avoiding euphemisms. We need to respect patients' wishes and choices. We need to check who we do and who we do not have permission to speak with. We need to assume that there is no record to the contrary and the patient lacks capacity that they would want us, the family, to understand. We need to not avoid difficult conversations. We need to accept that conversations may need repeating over and over again. We need to attend to the care of the body and to carers' emotional and practical needs as soon as possible after death. Involve. We need to involve the patient in decisions about their treatment and care to the extent they want to be. We need to involve those identified as important to the patient in decisions about treatment and care to the extent that the patient wants them to be. So how do we involve patients in their care? How do you involve the families of patients in their care? Healthcare professionals currently seem wary of doing the wrong thing. What we must do. We must involve patient and family who need to know who the senior doctor in charge is, who the nurse responsible for care is. Decisions must involve consideration of the benefits and burdens and risks of any intervention that we do. The patient's own team should be involved at the earliest possible opportunity. Decisions which can wait for their own team should do so, but not to cause unnecessary delay. All actions taken must be in a patient's best interest. Conversations with the family. We need to inform family and carers with the consent of the patient. We need to be explaining the situation or treatment plan which has been decided upon on clinical grounds. We need to be involving with the consent of the patient, engaging family as part of the patient's team. We need to be consulting where patients lack capacity, asking family for the knowledge of the patient's wishes to inform best interest decision making. Decision making where patients lack capacity and only if lasting power of attorney for health and welfare is present. Then the lasting power of attorney makes decisions for patients lacking capacity. Support. The needs of families and others identified as important to the patient are actively explored, respected, and met as far as possible. What concerns of families of those thought to be sick enough to die do you need to explore? How can you support families of those thought to be sick enough to die in the environment in which you work? What we must do. Family must regularly have their needs assessed by staff. Family must be welcomed and able to spend time with the patient. Families should be able to assist in care if patient and carer wishes, but should not be assumed to want to or left to do so. Families should have their expertise acknowledged. Family must be given practical support and access to facilities. Family must be prepared with practical information for what happens at the time of death. Family must know how to contact staff when patient is dying. The family must have their own spiritual and religious needs assessed and addressed. The family must be emotionally and practically supported after death. Planning and doing. We need to develop an individualised plan of care for each patient, which includes food and drink, symptom control of the common symptoms encountered in the terminal phase, psychological and social support, spiritual support. That individualised plan of care needs to be agreed, coordinated and delivered with compassion. What would be your plan of care for a patient who is sick enough to die, with fluctuating consciousness, agitation, unable to swallow reliably medication, who has previously needed regular analgesia? What we must do. We need effective and thorough holistic assessment of a patient's needs, which results in an individualised plan of care according to the wishes and preference of that individual. With respect to eating and drinking, we need to support to eat and drink as long as it's safe to do so. Respect informed decision to continue despite aspiration risk. Consider clinically assisted hydration or nutrition in line with GMC guidance. We need to provide mouth care and personal care to maintain dignity. We need to prescribe medications in advance that are targeted against specific symptoms. We need full explanations to the patient and the family of the purpose of those medications. We need to inquire about the cultural and religious beliefs of a patient and their family, and we need to ensure the availability of the respective chaplaincy team. We need to coordinate care at handover with clear plans and to transfer those plans when required. We need to transfer DNA CPR decisions made elsewhere. We need to involve the specialist palliative care services when required. This document, Treatment and Care Towards the End of Life, generated by the General Medical Council, is targeted at the medical profession, but it is appropriate to all health and social care professionals. It was published initially in 2010 and is consistent with current legislation. It's based on established ethical principles of the respect for human life, protecting the health of patients, treating patients with respect and dignity, and care of the patient being our first concern. It provides a framework for decision-making in care towards the end of life. The guidance recognises that providing treatment and care towards the end of life will often involve decisions that are clinically complex and emotionally distressing, and some decisions may involve ethical dilemmas and uncertainties about the law that further complicate the decision-making process. Within the guidance, it refers to overall benefit to be taken into account when making treatment decisions. This is the GMC's term to describe the ethical basis by which decisions are made about treatment and care for adult patients who lack the capacity to decide. However, for those patients who have capacity, it is our duty to elicit patients' preferences and wishes for care. That together, the patient and doctor will assess the situation. The doctor applying their knowledge, experience and clinical judgment to identify risk, burden and benefit of investigation and treatment. The patient then weighs up that information and communicates their decision. If a patient asks for a treatment which is not considered clinically appropriate, further discussion is required. Engagement of another second opinion may also be necessary. And finally, access to legal representation may be indicated. For adults who lack the capacity to decide, the decision-making process is as follows. Firstly, we need to be clear what decision about treatment and care is to be made. We need to determine whether there is an advanced decision to refuse treatment, whether a lasting power of attorney has been appointed, or whether there is a record of a patient's preferences and wishes. We need to take responsibility for deciding which treatment will provide overall benefit to the patient where no legal proxy exists and you are the doctor responsible for care. You must consult those close to the patient and members of the healthcare team to help you make your decisions. We only have one chance to get it right. From Dame Cicely Saunders, how people die remains in the memory of those who live on. Thank you.